Welcome everybody to this week's COVID-19 webinar presented to you by the International Association of Fire Chiefs. I'm happy to announce that we're sponsored by FirstNet, built by AT&T, 5-Bugle partner of the International Association of Fire Chiefs. Want to let you know today's audio is being broadcast voice over internet, so make sure your computer speakers or your headsets turned up for your volume. If you have any technical difficulties, there's a phone number and a help WebEx number. So it's my pleasure to start off today with, as always, the IAFC President, Fire Chief Gary Ludwig.
Good afternoon, everybody. Hi, again, my name is Gary Ludwig. I'm honored to serve as the President and Chair of the Board for the International Association of Fire Chiefs. I want to thank everyone who's joining us on this IAFC Coronavirus Task Force webinar, either directly or later when you listen to the recording. Again, we also, as Dave said, we want to thank FirstNet, who's sponsored by AT&T, powered by AT&T for this webinar. As you know, the IAFC represents the leadership of over 29,000 fire departments in the United States. Our Corona Task Force is chaired by Chief John Sinclair, and he has a large spectrum of experts on that task force. We're going to hear from some of those today. This is our third webinar, and we will be conducting them every Monday at 4 p.m. Eastern Standard Time. Last week, I was able to ramp up an economic task force to help our members access funding from the third stimulus bill, and also prepare for what's going to probably be a recession, a projected recession that's coming. These webinars in the future will also include members from our economic task force to help you navigate through the challenging economic times that we were facing. So without much ado, I'm now going to turn over to my good friend, Dr. Jim Augustine, who will bring us the latest medical information, and then we'll hear from some of the other panelists as we progress through the day. But again, thank you for joining us today. Jim?
Chief Ludwig, thank you very much. I hope everybody can hear me okay. This has not been a good week in terms of the spread of the coronavirus in the United States. So we're going to move quickly through what impact this will have on the fire service, both in the coming week and in the weeks to come. We are at the phase where there is widespread community dissemination by people with and without symptoms, and some symptoms are minimal. Increasingly, though, you are challenged by patient interactions where the patient is sick, and I'm going to explain that to you as part of the process today. The presentation symptoms are wide, and we, again, are finding more and more ways that patients can present. There are still no single or combination of herald symptoms that make coronavirus different from other seasonal infections and from things as simple as allergies and strep throats, which are common this time of the year. The New York City EMS system is at record call volumes, and you've seen the lines grow in the New York City area. This should indicate to us the potential problems that can occur in our systems, and that even the largest systems can be overwhelmed. We always begin with what is good for our people, and if you'll advance a slide, please. Personal health and safety is foremost to the chiefs and to medical directors like me. We are arriving at the point where your stations and living quarters should be sterile in terms of who is in headquarters, who is in the fire stations and EMS stations, and in particular, who's in the living quarters. It is very prudent at this point to be checking personnel as they arrive for their shift or arrive for a response. First, asking about symptoms, if they are experiencing runny nose, sore throat, dry cough, fever, other symptoms. If so, stop. Ask them if they're different than seasonal things that they might have. If so, then they really need to be run through an entire screen for their potential for coronavirus and what they could either bring to the rest of the crews working with them or the patients they're serving. And then a temperature assists you in being able to determine if an infection is present. You should have developed by now a form for each of your staff members, and for those that are in a quarantine status, it should be 14 days in length. But at least at this point, for each member as they arrive at the station for shift or response, and then it is very prudent for them, if they're on a 24-hour shift, to be checking their symptoms and temperature twice a shift. It is time to start seeing morale effects on the workforce, and that is something as chiefs we have to be, again, very well adjusted to this point where things get tough for our members, tough for their families, and as we go into the coming weeks, worth even more of your effort. We are arriving in a system where the growing number of patients are now going home. So they get checked at their healthcare practitioner's office or go to the emergency department. They are found not to be ill enough to be admitted, and they're sent home with a set of instructions that at the end of it always says, if you get worse, return to the emergency department or call 911. So it's very important that in those situations when they do get worse, that our crews respond expediently and are given information that there's a potential coronavirus patient at the address, and oftentimes respiratory protection indicated is the key term used by the 911 centers. There's a growing number of areas that are developing no response processes, and public health contributing on the back end to make sure that if someone calls 911 and says they are ill, and it's one of the herald symptoms, but they're not very sick at this point, that we can use that opportunity to put them into the Omega platform for those of you in the IAED system, and then hand off to public health or to one of your mobile integrated healthcare programs so that the patient or the family member can receive that care. That is typically not the situation with patients who've already been diagnosed with coronavirus. In those patients or the family member who's calling for them, they've already received the diagnosis and they're getting worse. And then it's our responsibility to move very quickly towards response, get the person the care that they need in the field, and transport them to the hospital. I think all of you are aware also that any of our senior care sites are at a huge risk. And many of them are developing or should develop a doctor-nurse evaluation team that is going into the nursing home rather than the usual process where someone gets ill in one of the senior care facilities and the 3 buttons get punched, 911, and you're asked to come and remove the patient. Instead, those areas in many cases are considered sterile, and it is better and better public health policy to have them have a diagnostic team come to them and make decisions. And in many cases, they can have care delivered in the senior care facility rather than removing them out to the hospital. There's a growing number of places where there's identified hotspots in the senior care facilities, and those are facilities that in particular should have an evaluation team that is able to come in and take care of patients there rather than removing them all. Our problem that is coming up at this point, if you will, is our patient population is again oftentimes very well hidden. From the time of exposure until onset of symptoms is typically 4 to 5 days. And during that time, they are typically asymptomatic. We believe they are not very contagious at that point, and that's been a continued theme. At some point, they do become contagious, and they have onset of some symptoms. And as we move into a new testing phase now, they're going to get a diagnosis that they have the coronavirus. At that point, they're sent home, and then a period of time, 5 to 7 days, where they may not be very symptomatic and may be thinking actually that they're getting better, when in fact the virus is just taking its time setting up camp in their lower respiratory tract, and it takes that 5 to 7 days for them to get ill enough to become hypoxic, to get significantly febrile, to get short of breath, and then onset of very severe disease is 7, 8, 9 days out. And then we're faced with a rescue situation in the hospital, and the discussion about how many ventilators is very appropriate at that point. So that's the challenge with the coronavirus, and a challenge with us understanding what the total load is in our communities, and being able to get information when patients have already been evaluated, given the diagnosis, and they're now getting sicker. We should expect they're further along down this line. And very importantly, as they move further down this line, it is very clear that they get more infectious towards your personnel and towards the personnel that are going to care for them in the emergency department in the hospital. Go ahead. So our patient approaches, again, begin with correct personal protective equipment use. We're all in shortage condition. We're talking about reuse strategies and about disinfection strategies, et cetera. The most important of all of the personal protective equipment is a mask on the patient, and that is a surgical mask, not an N95 mask. That traps many of the droplets coming out of the patient's nose and mouth and makes them much less infectious. And anything that breaks the seal around the patient's nose and mouth is what puts our providers at higher risk. So a mask on the patient is the first step. Minimizing the number of our response people that are contacting the patient, very important. Minimizing the contamination of any of our equipment. Our standard PPE for the providers is an N95 when available, goggles or a face shield, disposable gloves, and a gown or coverall if the patient is coughing or sneezing. In high-risk encounters, when you have to use an airway maneuver, it is very clear that you have to have gowns and coveralls on and something to cover the head of the single provider that is up near the face of the patient. Nebulizer treatments need to be done outside with crews that are significant distances away, and the patient's clothes covered with a sheet or something else that you're going to leave at the scene. Please don't let your EMS people treat coronavirus patients with a nebulizer in the back of an ambulance or in another enclosed space. That's a high infection encounter and shouldn't take place. We are now entering into the testing phase, and many of you have heard this week that Abbott Labs has released a new test that will be positive within 5 minutes. That and similar tests will be very, very important for us to begin to implement. And there will be new strategies both for patient care as well as for the care of our providers and for things like our return to work evaluations. There are two types of tests, and make sure you understand the difference between them. There are direct tests looking for the virus in and on the patient. That's done with a swab in the nose and occasionally for some patients a swab in the mouth. It looks directly for evidence that the virus is there, and typically that test can be done fairly quickly. Right now, the problem is a shortage of reagents and a shortage of technicians makes the test itself spread out over a number of days, and you have a difficult time because you can't get answers back. Later on, we will be looking at the availability of tests on blood of patients and blood of our providers. A blood sample will be drawn, and we will look for antibodies against the coronavirus that have formed in the people who've been exposed and infected by it. And it will be important for us to be able to tell who has been exposed, who has built antibodies, and therefore who is protected from, we believe, will be protected from future coronavirus infections. And we believe at that point that person will not need a vaccination at a later time, and that they may sustain some period of time, and we don't know if it's years or the rest of their life, where they will be protected. Make sure that you understand testing strategies are going to change once we get the availability of tests that can give us a rapid answer about the patient and about our providers. Some departments have begun thinking through doing testing at patients' homes. And City of Miami will be trialing this process, and Miami Beach, its neighbor, is developing a COVID unit, which is used for responding to COVID patients and will also incorporate the testing process. With new testing, then the headline is available for you here, that a mobile integrated healthcare program, City of Miami, will take the testing right to the home of patients. And I think in particular, this will be used in senior care group homes and in extended care facilities so that we can keep better tabs on who potentially is infected and where new hotspots might be. Quarantine and isolation. Those are, again, terms that you have to become comfortable with. Quarantine means not sick. Isolation means the person is ill. This relates to your staff. You have to have the right places for them to quarantine or isolate, and the support that they will need for what is somewhere between a 14-day and a 7-day process. You will need to have the forms available so that for 14 days they can track their personal health, indicate when symptoms or a temperature has begun to take place. And again, those testing strategies are something you will have to develop with your medical director and use the test right now in the nose to find out whether the virus is there or not. Finally, this is one of the forms. So we have a sample 14-day form here. I'm happy to give this to anybody. I've sent it out all over the country. Very simple, twice-a-day testing for symptoms and an oral temperature. Go ahead. All right, high-risk exposures, CPR, intubation. We are modifying protocols to reduce the exposure of our people during these very high-risk situations. And in some cases, we're moving very quickly towards termination of resuscitation so that short intervals are required between one person or two person that are your scout people going in, trying to figure out what's going on with the patient. If they have a high indication that this is a person at the end of a coronavirus infection, our resuscitation rates are near zero, and it may be that online medical direction will ask you to terminate resuscitation before it has really fully evolved, and in particular in asystole situations that resuscitation may not be attempted at all. I want to tell you over the weekend that the Ryan White Act was amended specifically to include the coronavirus. And with that, the information exchange that goes on with hospitals and public health should hopefully be more friendly towards you as chiefs trying to find out the status of patients who you've transported. And that's going to require local efforts, again, working with hospital infection control and with the public health epidemiology staff working to exchange information. We've run into shortages of hand sanitizers, and I want to let you know that local breweries oftentimes can help. There's a WHO formula for the production of hand sanitizers, the alcohol, aloe, or hydrogen peroxide that can be used to make these. And we also got a note today. Our school system has a lot of hand sanitizer, and since many of them are now thinking that their school season has ended, they may have boxes of hand sanitizer available from the school system to help. And then finally, I want to talk about the transition at the other end, which is at the hospital and emergency departments. You all probably by now have seen pictures of tents. And if you can move to the next slide, these tents are placed outside typically the emergency department and are used for some form of screening or triage and greeting process for both patients and other visitors and staff members of the hospital. So now we have tents set up outside, and as you can see in this photo, they have generators outside, they have porta pots outside, they have some traffic issues. And this weekend, as the storms were rolling through some of my service areas, an advisory from the regional incident management team that crews that are working in these tents outside probably ought to move inside because wind gusts were going to take them down. So there's a whole new set of priorities here for the fire service, looking at utilizations of tents outside the hospitals and what further risks there might be And then again, we're typically taking Wi-Fi or hardwire outside in an attempt to get the clinical staff there very functional, to be able to register patients outside, do appropriate screening with appropriately protected staff. And as weather conditions are changing this time of year, just be alert that these may present a little bit of a risk. So this week, we are moving into testing phase, more critical patients. In many of your areas, your hospital systems and the state university have begun to put together a flow chart about when they expect highest volumes of patients and the greatest stress on the healthcare system. For the states that I work in, we're still about 2 weeks away. So that gives us a planning window for us to know how to deal with the sickest of patients, even though we're at a phase right now where many patients are not real sick in our communities. We need to take advantage of that window at every level to make sure that we're set up to use all the resources that we have available to take care of the community, but to protect our staff as well. Chief Ludwig, thank you for the opportunity. As always, any of you who want to send a note to me can send me a note, and I answer a lot of the questions directly online. Thank you very much, and I'll pass it on to Gary.
Thank you, Jim. Again, another outstanding piece of, I don't know what to say the words are, but again, just outstanding information. And thank you, Jim. Thank you for being a part of our task force, and thank you for just sharing just a plethora of information. We appreciate it. At this time, I'm going to turn it over to our chair of our task force, which is Chief John Sinclair. John?
Thank you, President Ludwig. I'll just go right in and start building a little bit on what Jim was just talking about, put a little bit more meat on a couple of the bones that he laid out. One of those has to do with our station. I think that it is vital at this point across America that we look at locking down every fire station and locking them down from the public, making sure that just the crews are in there, and taking a look with our departmental health and safety officers if we're doing everything that we can to sterilize the station. This weekend, I was discussing with some colleagues about what are the possible entry points for a virus into our fire station. And if we close our front doors and we stop doing community blood pressures, things like that, don't allow the public in, I think that most people are going to understand that in our community because we are now in the social isolation phase. But simple things like fire stations are 24/7 operations. People have to eat, so where are they bringing in food and supplies, and are we cleaning up the packaging? Are we deconning the packaging that is coming in? We may have just wiped down the counter. Now we bring in things from the grocery store. We'll lay that out. How many people have touched that? So I think that it's time for us to really rethink our decon process and take a look at that. The next issue is, if you haven't taken a look at your mutual aid program in your state, in your community, I urge you to do so. Over the weekend, Fire Department of New York put out an urgent call for mutual aid because they had doubled the amount of EMS calls that they were going on. And I think they likely got some, but they had requested out of the 3 states surrounding FDNY to assist. And I don't know as what they had that much mutual aid come in. They do have a part of the FEMA contract or the HHS contract. They've got an series of ambulance strike teams that are up there, and one of the hospital ships are there. But obviously, New York is being very hard hit. When we look at the hot spots around the country, the state of Washington continues to be a hot spot. But there's some growing hotspots out there down around New Orleans, obviously in New York, the Chicagoland area, the Detroit area. So we're beginning to see some hotspotting going on. And if you call for mutual aid, be ready for the fact that people may not be able to give you mutual aid because they're holding resources close to the chest. On this morning's FEMA briefing, there was 15 of our USAR teams that are currently not available to deploy because they are busy. All of their resources are busy combating the disease locally, so they cannot form up teams. So just understand that mutual aid may not be available, and you may have to get creative on how you do that. It is time for you to sit down with your team and talk about, if mutual aid is not available, what do we do? Same thing goes with your PPE supply. Currently, as we look at the national numbers, and we're beginning to get some supplies in the pipeline, but the larger issue, pipelines outside this country, and before we spin up, PPE is still a hot topic, and it is still difficult to get. So what you've got is probably what you've got. There is some that is coming out of the Strategic National Stockpile, but again, it's being sent to those places that need it the most. Because of our supply issues, we're seeing an uptick in opportunists. And we're seeing people out there with scams, and we have seen people that have gone out and repurposed N95s and said that they're good, and turns out that they are not. So just be careful. There's a lot of people out there that will tell you that they've got supply. And I talked to one chief over the weekend. He said that he had a supplier call him up and said that they could drop ship him supplies, but they had to pay for it up front. He paid for it up front, and then he got notice that they were back ordered without any real knowledge of when that could occur. So I would make sure that you trust your standard supply routes and be careful of opportunists out there. It is also time for you as EMS agencies, as fire agencies, to be having a discussion with the public health folks, your public health officials, and your medical control on what to do in the setting of austere care or crisis care. Do you change your standard EMS operation? What types of patients are going to be left at home? Do you need to have a state level of change in your operating protocols? Is that something that your medical program director can do? If we get into austere care, if we get into not everybody is transported, then you're going to need to have the state look at that. You're going to have your local medical program director look at that. And those are largely going to be system to system, state to state. But it is important that we engage in that conversation right now before we're in the midst of it. If we take a look at our colleagues in Italy, they are faced with this on a national basis. Certainly, we're probably getting to that crisis care stage in certain hospitals in New York City, and it will approach other places across the country. The other grim issue that I think that we have to plan for is mass death. Now, as EMS agencies, we may or may not have a stake in that, but a lot of fire chiefs out there are also emergency managers, and they certainly do have a stake in making sure that we are planning for that. We need to be at the table to talk about that. If you're in Washtenaw, Washington, you may be able to deal with a couple of people a day dying, but what if we're getting 10 people a day dying? So it's the larger cities and the smaller communities that all have this as a potential to have to deal with. And I think that is absolutely incumbent upon the fire chiefs to figure out what is their plan locally. And if they don't have a plan, to work with emergency management and come up with at least an understanding of what you're going to do. The good doctor talked about mental health for our folks. You know, at this point, there are some systems that are in crisis, and we are beginning to see the stress of that play out on the healthcare workers and out on the EMS and the EMS providers and the fire fighters that are out there. So make sure that you tie in with your whoever your mental health providers are and see if we've got the ability to have some check-ins with the areas that are hit hardest. The mental health of the community is also out there. The mental health of the community is going to look a little bit differently as we extend this shelter-in-place order, and be expecting and tie in with your law enforcement colleagues about what happens when we begin to get cracks in the social contract and we begin to get civil disobedience, because that will likely happen the longer that we are involved in this. And we've got people that will disobey the health order. What do we do relative to that? So make sure that you are tied in with your law enforcement colleagues as to what the fire service role is in civil disobedience. If we can go to the next slide. So, you know, lessons from the front lines, I'm going to turn it over to a good friend and colleague here in a minute. But one of the things that we're going to have to do, and I'm going to ask each of the fire chiefs out there to do this, is to think about while you're in the middle of this, we're going to have to eventually, when it's over, do an after action report. And what were the things that worked for you relative to planning leading up to this? Did you plan for it? As you entered into it, did you have the leadership, the strategic partnerships? Had you trained the workforce to be ready for that? And we're going to have that discussion afterwards. So to sort of go to that pointing into the spear, the person that coordinated the very first COVID-19 response in the United States was my good friend, Deputy Chief Shaughn Maxwell. And Shaughn has over 30 years in fire and EMS service. He's won numerous awards for he and his organization for his EMS excellence. He is working on a master's in the human behaviors and human potentials. So, Shaughn, Chief Maxwell, I'm going to turn it over to you, sir.
Thanks, Chief Sinclair. Can everybody hear me okay?
Yes.
Okay, perfect. Thanks. Well, we have been in it here. I was just looking at my phone and my email. We've been in this now for about a month, and we've learned a lot. And I can say just between the three of you that have spoken already, I think you guys are right on the mark. I think what I have to add is just kind of infusing lessons learned over the last 30 days. And just kind of going back to my background, it's really human factor psychology, and it really infuses all of this. And I think one of the things we have to do is we have to change our mental model. Our mental model of the world is how we think our world is and how things should react, but our mental model has changed. And so we need to rapidly adapt to that and kind of break free of the old model of how our systems work right now. It's changing every day. I did think that was an excellent point. A few of you have made on the stations. We locked down our stations 2 or 3 weeks ago. We actually spray our boots off, hand sanitizers, and everybody takes a temperature and does a mental review of their signs and symptoms before they enter. And before you enter the core command center, you do it a second time. So we have 2 layers of defense there because we're trying to keep our command staff fully protected. All the operational crew are not allowed, even in the headquarters. All the mail, everything they pick up is now outside the headquarters. So we have almost a dual or triple layer of defense to keep our command staff as disease-free as possible. So some of the lessons learned from the front lines, I will say, we can't prove any kind of cause and effect, but we've been doing this pretty heavy for a month now, and we don't have any. We only have one person who's positive actually out of our 300 members, and that it was not a on-the-job exposure. So I'd say one of the things we did, kind of getting back to my slide there in the front, is we made hard decisions early to go up with PPE, and the optics on that and the politics on that can definitely be challenging, but I definitely think it was a success point. And we went to goggles early, and that was definitely frustrating for the crews because you fog up, they get sweaty. We looked at anti-fog device. We actually found a really good wildlands goggle that's splash proof that we finally settled on, and that's helped a lot with the comfort and rubbing a little anti-fogging material in there. The initial data came out that rescue airway was safer because you didn't have your head down in there for the aerosolization, and now the research is pivoting towards intubation is better. And you have to, there's a thing called sunk cost bias, and you can put a lot of energy into protocols and decisions, and then you have to be able to not get too anchored and be able to change quickly on those, especially with the research, how fast it's changing. Can you do the next slide, please? So these are the positions we set up, and it's worked pretty well. We have a science officer that is scouring the research. Most of the research is now free, and so we have one officer that just scours the research every day, and it's been incredible intel on helping us have an informed response. We have a document officer. We have a thing called the playbook. All the documents are in one place. We originally had them in PowerPoint. Now it's in Word, and that document, sometimes it's daily, sometimes it's every 48 hours. That the playbook basically has response, treatment, decontamination. It has all the steps in it for providers, and it gets updated as the science changed or the CDC or Department of Health gives us intel on that. But before the documents there were multiple documents. You want all your documents kind of in one document so people aren't looking. People don't have time to look. We have an infection control officer. That is the area that's kind of blown up for us the fastest for provider exposures, people that are sick. We have 2 people now, and it is their full-time job to work with all of our employees and give them information, give them return to work instructions, quarantine, isolation. But narrowing that down to 2 people, the last I checked with them was last week, and they were handling at least 50 calls a day, working with our providers. And then a logistics officer, they say a war is successful in logistics. That's been really true. And you need to have someone in that position that is very industrious and creative, and I talked about breaking your mental models. They have to just be thinking of new ways. One of the newest things we've looked at is they have a CPAP, UV rays for a CPAP. You can throw your CPAP machine in a little UV box, and as long as it's the right UV wavelength, which is UVC, we're looking at decontaminating using that. So your logistics officer just has to be really a creative person. And then the data officer. We always talk about data in the modern fire service. Not only do you need to take that data, you need to ask the why and figure out the meaning and figure out how to operationalize that data to inform your response. And so when you're pulling that data or deciding which data you're going to have, you have to be really smart about using that data as well. Next slide. And then here's another thing we looked at. We were going to put out the scout units or alternative response units. We've been looking at for a couple of weeks. And there was a lot of people with a lot of urgencies to launch those into the streets. But I can tell you our call volume here keeps dropping. And I'll talk about that in a minute, what might suggest the reasons behind that. But across Washington State, where we're at, ED volumes are down 50% from their numbers in October. So we don't want to launch, it's kind of the right intervention at the right time. We don't want to launch that intervention too early, and whether it's expending funds or burning out the workforce or just having the workforce sitting around. So it is still a time to do the right thing at the right time. Next slide, please. Crisis communications, and this is interesting, and this is a delicate balance, but I know other places in the country have adopted this. You know, when things were changing rapidly at first, we were putting out our playbook daily because the information was changing daily as we got our hands around it. Now it's moving to every few days, or we're out to a week now. It's important to over-communicate. Google says, you know, when someone is tired of hearing the message, that's when they know they've heard the message. But over-communication takes skill, and there's a lot of human factors involved in that. And some of the things I put on the slide here, you don't want complex words. People don't remember complex words. You want similar formatting. You don't want a bunch of noise. You don't want a bunch of like circles and squares. You want short, simple words that are actually not, you don't want similar words either, and you want it all to be very standardized formatting. Otherwise, the message gets noisy and it gets lost. And then you want to send that out on a regular basis. We send training out with donning and doffing and our playbook. We send it out daily, even if it doesn't get updated daily, because there's people off on vacation and sick time, and we know repetition is one of the keys to learning. Next slide, please. I guess I jumped ahead of myself there too. You know, we push out videos every day, and the crews are required to watch those every day because it's surprising how people don't know how to don and doff properly. And then the other message we're constantly putting out there is you need to be, you know, I think we know that firefighters don't like change. Well, we set the expectation that you need to do what we ask you to do today, but it could change tomorrow. So set that expectation that change is going to be constant. One of the things our medical director did here is, since there is such a volume of training going out, he's going to really lower the requirements to recertify this year, including a lot of the practicals that have to be done in person. And so that's kind of saying, you know, we're doing this regular training right now, but know that we're going to take the load off you later. Next slide, please. As I said, you know, in our area, you know, we're seeing the massive rise in volumes in places like New York. Ours has been down for a few weeks, just abnormally low. Like I said, in Washington State, the ICUs are full and they've created extra wings, but the emergency departments are down by 50%, and we're going pretty slow as well. And what are the other factors that are causing that? You know, shutting down schools, that idea came from flu modeling. So we might be slowing the spread of flu. Another strange thing that I thought in the hospitals around here, I thought mental health would be up with anxiety and fear and depression, and mental health is actually down. And I couldn't explain that. And motor vehicle accidents for us are also down by about 50%. Next slide. This is if you see on there, this is the University of Washington has a great site going, and you can look up your state, and they model peak death and peak resource use, and when you're going to hit your peak. For example, here, Washington State, looks like our peak resource and our peak death rate is going to be on April 24th. This weekend, it was April 19th. So this is a dynamic model, but you can look that up. and you can pull down your state and look that up for your state as well. And that's just so important, because we don't want to burn ourselves out early. We need to, this is a marathon, and it's good to kind of know where the peak may be. Next slide, please. So just kind of the final thoughts or final learning points. I think you'd have to be really intentional about making decisions. It's so easy to make knee-jerk reactions, and I've been watching it happen. Just don't freeze up, but also be methodical. There is time to make really good decisions, and it's saved us many times. I think the community spread definitely is very strong in the Seattle, Washington area now, and I think, considering our rear guard, what I was speaking with our team, what I'm concerned about now is 79% of the cases are untraceable. And my fear now is it's going to start coming into our stations through our crews being together, our crews going home to their families, or going to the grocery store, or being out in the community. And so I think what we need to be thinking now is how do we practice social distancing in the stations, and maybe even with our families. I don't have a good answer on that. And then my final thought is, we've been super industrious in figuring out PPE and hand sanitizer and those different things, but don't settle on one thing. Like Chief Sinclair mentioned, they will fall through on you. So when we're looking for an N95 or a surgical mask, or a way to disinfect our N95s, we're multi-tracking. We're looking at 4 different ways at the same time to make that happen. I think that's my last slide. Let's see. Yeah, so I guess my conclusion is, just be careful. Don't settle on ideas too quickly. Don't think that the first idea is the best idea, and really be thinking about your mental model of the past, what's worked in the past may not work. You need to be thinking in second order thinking is, okay, if we make this decision, what's the cascade of events that will occur when you make that decision? So with that, I'll turn it back to you, Chief Ludwig. Thank you for the opportunity.
Thank you, Shaughn. I was feverishly taking notes there. You had such outstanding information and some very great, good best practices there. One of the things that I was brought to my attention today is that the CDC on their website actually has a burn calculator that you can enter your current supplies in there, N95s, gowns, goggles, that sort of stuff. It's a spreadsheet you can download, and it also allows you to input data. And it kind of gives you a burn rate on the material going through, so that you don't get caught flat-footed without materials and without PPE. So I encourage everyone to go to that website, the CDC's website, or just Google the PPE burn calculator, and you can download. That's a free download from the CDC Excel spreadsheet to kind of calculate. And we continue to get reports of departments without N95 mask, and so we are telling people, contact your local supplier. If your local supplier is not able to provide those N95s, you need to push that request up through your EMA to your local FEMA coordinator, your FEMA region, and see what you can procure out of the national stockpile there. They indicate that they have ordered 600 million N95 masks, but there's a little disclaimer there that that'll be over the next 18 months that those will be delivered. So we're certainly finding ourselves in this unique times. With that said, I'm now going to turn it over to our Government Affairs Director, Ken LaSala, the IFC. And as we know, the CARES Act was passed by Congress last Friday and signed by President Trump. It's $2.2 trillion. We're not happy with all that came out of there and how it impacts the fire service. We're going to continue to advocate and work for that. But I'm going to turn over to Ken, and he'll be able to tell you more about that. So, Ken, it's all yours. Thank you.
Thanks, Chief Ludwig. Thanks for the introduction. I really appreciate it. Like you mentioned, on Friday, the President signed the CARES Act. That's Public Law 116-136. There's a couple provisions in there for the fire service, or at least there's, quite frankly, there's money in there that fire departments may be able to reach out and get for reimbursement. The first thing is there's $100 billion in the HHS Public Health and Social Services Emergency Fund. And the beneficiaries of that, those folks who can apply for funding, are what they refer to in the bill as eligible health care providers. That means public entities, Medicare or Medicaid enrolled suppliers and providers, and such for-profit and not-for-profit entities not otherwise described in the proviso, but that the Secretary must specify. So it talks about having like a rolling application process and things like that. The IFC is currently reaching out to HHS to actually be able to access, to learn information more about how this program is going to be run, and to find out how fire departments can access this money. There's also $100 million in the AFG program, specifically for helping fire departments buy equipment and resources in responding to COVID-19. We've already reached out to the AFG office to find out when that application period is going to start, and that's something as soon as we get information, we'll be sure to let you know. There's also $45 billion in the Disaster Relief Fund. I would like to highlight that because there's two guidances out there which are on the IFC's webpage. The first is one by Chief Bryant, which talks about eligible expenses. That includes backfill and overtime, and also supplies and even apparatus mileage. He also has in there some discussion about the forms you need to be taking to using to take account of your costs. So I recommend both taking a look at on our website Chief Bryant's, the U.S. Fire Administrator's guidance, and then also FEMA's Simplified Public Assistance Application. As we learn more about how these state emergency managers are going to be managing this, we'll be sure to let you know. But I highly recommend at this point that you reach out to your state emergency manager. Going on to the next slide, there's also $100 million in there for the EMPG program. That funds local emergency management and will help fire chiefs or also local emergency managers basically start addressing and planning for some of the issues which Chief Sinclair talked about during his presentation. There's also $7 million there for the U.S. Forest Service's Wildland Fire Management. That's to be spent at the discretion of the Chief Forester. We think that's going to be spent mostly for equipment and PPE, and then also some baseline health monitoring for contract wildland firefighters. But wanted to make sure you knew about that. There's also $16 billion there for the national stockpile. That's something which Chief Ludwig was referring to a few minutes ago, to help the national stockpile be able to, basically start getting all the equipment they need, and hopefully make it available to you all. Moving on to talk for a couple of minutes about what we're doing regarding the executive branch. One of the first things we're doing, like I mentioned before, is we're trying to work with the Departments of Health and Human Services and also DHS to make sure the fire departments can start learning more about the appropriations which Congress has passed, so that way fire departments can start getting reimbursed. One of the other big issues we've really been working on, which we touched on a little bit today, is regarding testing priorities. Currently, the U.S. Public Health Service actually put out a chart which says that it sets 3 levels of priorities. Priority 2 would be first responders with symptoms for testing. And then the third priority for testing would be quote-unquote critical infrastructure workers with symptoms. So first responders would fall under that rubric. So what we've done is last Friday, the IFC and other fire service organizations actually sent a letter to the Secretary of Health and Human Services and asked that the priority be pushed up so that fire and EMS personnel could be priority 1 testing. That way we could see whether or not a firefighter or EMS personnel have been exposed to the coronavirus, to see if they have any symptoms, or even more importantly, if they're asymptomatic. And that way fire departments could start taking the right decisions about whether or not to quarantine people or whether or not to take people off of quarantine. Again, we continue to work with the different fire groups to send letters to the White House, to the Vice President, talking about the importance of prioritizing getting necessary supplies to fire departments. And then also, we've also reached out and pointed out the importance that fire departments be let know when there's that there's basically a notification of drug shortages. So that's some of the things we're working on. The other thing I want to bring to your attention, and we actually have a guidance also posted on our website, the Bureau of Justice Assistance late last week put out a notice regarding the Public Safety Officers Benefits Program and COVID-19. And basically what they've said is that there is no presumption, and that the PSOB Act requires the evidence show that it is more likely than not that the virus resulted from the public safety officer's exposure while performing a line of duty activity or action. So a couple of things. One is if a family is filing a PSOB notice or PSOB application, one of the things that's important that we just talked about earlier was the Ryan White notification. It's going to be important if the hospital says that the firefighter or EMS personnel were exposed to a patient with COVID-19. And then in addition, the PSOB office said they will take any documentation they can get, including self-documentation. So unfortunately, if a fire department does have to file a PSOB claim, we recommend, the Ryan White notification, any type of self-documentation, any other information that you can have to submit with that application, because the burden of proof is that the evidence has to show that it's more likely than not that the virus resulted from the public safety officer's line of duty activity. So that's a quick update from the government relations world. I'm going to turn it back over to Chief Ludwig.
Thank you, Ken. And I sincerely appreciate all the work that you and Evan and Brandon are doing, our IFC government affairs people down on Capitol Hill, and also with the administration to try to represent the fire service and make sure that we're inclusive and included in this the funding that's coming through and what is rumored to be a fourth stimulus bill also. So thank you for all that you all are doing. So what Ken said is so important. We, as we indicated before, we ramped up an economic task force last week, and that economic task force met yesterday on a conference call. And the first action item we're going to try to get out to everyone is what fire chiefs should be doing right now, because it's so critically important that you try to access that grant money that's going to be coming down the pipe. While we've been on the phone, or while we've been on this webinar, I just tell the listening audience I got a text message from someone out of Ohio, and the city of Cincinnati has just announced that they're going to furlough 1,700 non-essential employees because of reduced sales tax and payroll tax will be coming in. So unfortunately, this is probably going to be the start of what we're going to start seeing. And it's so important that, again, we be ahead of the curve on this and try to provide our members with guidance and assistance on how to access some of this funding. So expect this webinar in the future to also include members from the Economic Task Force. Again, we'll be here every Monday at 4 p.m. Eastern Standard Time. So now I'm going to turn it over to my good friend, Amit Kapoor, who is with First Line Technologies. Amit is our resident expert when it comes to supply chain issues. And again, he has also provided a myriad of information on our challenges with supply chain issues. So Amit, I turn it over to you.
Thank you. I appreciate the time, and I'll try to make this as quick as possible, getting all the information out to everybody. Supply chain is tight, and everybody's seeing how tight it is by access to N95 ventilators, and we hear it in the news, and at times you're probably seeing it directly by interfacing with your suppliers. It's becoming more difficult, and mainly because a lot of states are putting in effect stay-at-home policies across the country, and these are difficult for suppliers to understand whether are they deemed essential. The National Association of Manufacturers is trying to push out guidance to these manufacturers and let them know that yes, you would be deemed essential and to keep operating, to keep manufacturing products. This has led into a couple other issues in terms of employees are sick or potentially sick. So the workforce to manufacture N95s or manufacture these products is dwindling. And what we're finding is some of them don't even want to come in anymore. And we're trying to resolve that by educating the workforce, letting them know about similar issues on the front line that you guys are dealing with mental health and stability at home, because a lot of people's families don't want them coming into work. So the best advice I have for fire chiefs is reach out to your local suppliers who you trust and to understand what their resupply is going to be over the next 3 to 4 months and get on a list. Whatever supplies you think you might need 3 or 4 months from now, get on their local list and understand when they'll be getting their resupply. And again, resupply is not always accurate. We're seeing promises from key suppliers through our supply chain. Well, they'll say like, we'll deliver to you in a week, in 2 months, 6 months, 18 months, and that is not reasonable. And that is something that needs to be addressed, and the National Association of Manufacturers is working on this. Even if you don't need items right now, if you're flush of N95s or flush of equipment like gowns, you still should get on a list because, again, we talked about the burn rate calculator. If you haven't seen it, please go to the CDC website. Chief Ludwig did talk about that. It's a great tool to understand what you're going through today and factor in what you might go through tomorrow, next week, next month. It's the long game. And I think we've addressed that during this webinar quite a bit here. You need to look from medical supplies all the way to PPE supplies. Cover everything that you're looking to source into the future. Please work with trusted suppliers. One of the issues that we're dealing with right now is watching for fake items that are in the supply chain. There's been quite a bit of reporting from the FBI and Department of Justice of these fake N95s, fake medical masks. People are coming out and distributing from China, from India, and they're not approved N95s. They're not reimbursable from our understanding when you ask for reimbursements from the emergency management side in the future. It's because it is not a real product. You want to ensure that you are checking against NIOSH's website, the FDA's website, checking for EUAs that are out there for those products. And fakes in general, obviously, will cause a high risk, and because a product will not be working the same way that NIOSH is qualified. What we're hearing is I've been dealing with about 20 emails over this past weekend and trying to catch up with people asking about general questions like N95 versus KN95s. And it's because if you go to 3M's website, it distinctly tells you about their equivalent, and what that equivalence doesn't really factor in is has been approved for use by NIOSH or by the FDA, and that is something that's being worked on and being developed over the next couple of days. And so keep looking out for guidance that changes every day about what products are certified, what products are allowed to be used within the workforce. There is a PPE inventory dashboard the IAFC has created, and it's a great dashboard with 162 responses before coming on the webinar. It's great because we can see in real time what challenges you guys are having out there in terms of what PPE you're looking for and what your burn rate might be in the future. So please fill in your information. The IAFC will definitely be able to use that to go back to supply chain issues that they're dealing with. There's been some guidance on reuse of N95s and the decon of N95s, and I want to just talk about this very quickly because we've been pushed a lot of information about they're seeing hydrogen peroxide. BioQuell has an item. There's been some decon sprayers to be applied to N95s. The only product we've seen so far that is approved for the decontamination of N95s is this new product from Battelle that they pushed out over the last weekend, the CCDS, where they can decontaminate 80,000 masks. That's been approved by a FDA EUA, and there are more products in the pipeline, but the Battelle product is the only one that can be done. I think they're going to be posting it on the task force website as well, coming up soon. But there's been some new innovations out there. People are coming up with different concepts for decon sprayers. We saw Tulsa Fire Department and some other fire departments have started utilizing a paint sprayer attaching to their SCBA. This has not been, these are great techniques. It depends on what disinfectant you're using. So please make sure it's an EPA registered disinfectant that you're going to be utilizing to clean your gear and clean your apparatus. And again, check on the EUA guidance. It changes on a day-to-day basis because products will not be reimbursed if they're not on that list in the future. Supply chain, I have good news. Supply chain from China is easing up. We are still about 2 to 3 weeks behind. So we're getting in power adapters, we're getting in fixtures to build out ventilators, build out N95 masks. It comes down to the small punch out of the metal that has to go on the nose clip. we're having issues with supply chain of metal, for example. So we are working on that. It is lightening up, and we're about 2-3 weeks away. That's my update here, Chief.
All right. Thank you, Amit. Again, just a wealth of information, and I think I speak for everybody online when I say we appreciate it. And we also appreciate all the information from all of the panelists today. If you have any questions, there's an email on the screen there that you can email our staff liaison, Dave Becker. Dave, is there anything you want to say here before I close this out?
Yeah, Gary, just a couple things. One, those of you that are looking for a copy of that personnel tracking form that Dr. Augustine talked about, if you'll email that email address there, I'd be happy to send it out to you. Would like to make sure that you all check out the IFC website, look at the impact dashboard, look at the fire EMS impact dashboard, and then that force protection survey would be greatly appreciated if you would fill those out that Amit mentioned there. We're happy to have this. Appreciate the sponsorship that we had from FirstNet, built by AT&T, as a 5-Bugle partner for us today. And just like you said, Gary, to make sure to remind everybody, we'll be here next week, next Monday at 4 p.m. Eastern Standard Time.
All right. Thank you, Dave. Again, I want to thank all our panelists today, again, who provided just outstanding and terrific information. I also want to thank Chief Sinclair and all those who are on the task force who are diligently working to provide information to our members and to the fire service. And finally, I want to thank our interim CEO, Rob Brown, and all the members of the IFC staff. I know who are working extra long hours and on weekends as we work through these challenges in this national emergency. Again, Dave said we'll be here every Monday at 4 p.m. Information in the future will also include that from our economic task force. As I said earlier, I received a text message that Cincinnati, I haven't confirmed that yet, but Cincinnati plans on laying off 17 or furloughing, I should say, 1,700 non-essential employees. In order to join our webinars in the future, please go to iafc.org to register. Again, I am so honored to serve in this noble profession with so many outstanding people who make a difference in their communities every day. Please join us on this webinar next week as we will provide the latest updates and information. In the meantime, everyone, please stay safe and may God bless these United States of America. Thank you very much.